Welcome to the deep dive. Today, we're really getting into something fundamental for anyone working in child mental health. We're looking at the Child Psychiatric Examination chapter from the big one, Kaplan and Sadock's comprehensive textbook of psychiatry. If you've ever felt a bit daunted by assessing a child or adolescent, well, this chapter lays out the roadmap.
That's a great way to put it. And our mission today really is to capture the core idea here. Clinical assessment isn't just about, finding a diagnosis. It's the absolute bedrock of child and adolescent psychiatry. The real aim is this deep inquiry. We're trying to pinpoint factors within the child, the family, their school, their world that might be causing the problem, making it worse, or actually helping things. And crucially, that assessment itself, it's got to start building that connection, that alliance with the family right from the get-go.
Okay, so let's dig into that core philosophy. Assessing kids. It's not just like a mini adult assessment, is it? What's the big shift in thinking?
Right. The absolute key difference is thinking through a developmental filter. You constantly have to ask, what should be happening at this age? Often, problems in childhood don't look like adult symptoms suddenly appearing. Instead, it might be a lack of expected developmental progress.
A lack of progress, like what?
Well, maybe a failure to develop functional social language skills. Or take a school-age child who just cannot separate from their parents to go to school. That's a developmental milestone they're not meeting.
That's a really key distinction. So clinicians almost need to interview about what didn't happen as much as what did.
Exactly. And you're constantly judging against this kind of normative line. Is this fear, this tantrum, just a typical passing thing, like a bit of separation anxiety when a kid starts preschool? Or is it so severe, so persistent, maybe causing so much distress that it signals a need for help? And even how symptoms look changes. Depression in kids, for example. It often comes out as irritability, maybe lots of physical complaints like stomach aches or headaches.
Not the classic adult picture, then.
Not usually. Things like intense guilt or, depressive delusions are actually pretty rare in children.
And the source even brings this back to infancy, mentioning those temperament categories. Easy, difficult, slow to warm up. How do they fit in?
Ah, yes, Chess and Thomas. Those temperaments give you an early clue about the child's basic reactivity and adaptability. So if you have a child who fits that difficult pattern, very reactive, intense, maybe irregular sleep or eating, they're starting with a baseline that might already clash more with the environment. It can make it trickier, to distinguish what's a treat versus what's becoming a disorder.
Okay, here's something the source highlights that might surprise some people. Comorbidity. We often look for the diagnosis, but apparently that's not the norm.
It really isn't. Comorbidity, having more than one disorder, is pretty much the rule in child psychiatry, not the exception. The data suggests maybe up to half of kids who meet criteria for one disorder also meet criteria for at least one more.
Wow, half. Why is that so common?
Well, part of it might be how our diagnostic categories are defined, sometimes borrowing heavily from adult psychiatry. But a bigger piece, I think, is what the source calls the ramifying effect. When a symptom impairs a key developmental skill, let's say attention difficulties, that problem ripples outwards. It interferes with learning social skills, academics, maybe regulating emotions. So one initial problem can branch out and lead to a much more complex picture over time.
That makes a lot of sense. So given that complexity and the fact that kids function differently at home, school, with friends, the assessment has to capture all that, right? You can't just talk to the child alone.
Absolutely not. Context is everything. A child's behavior is so tightly linked to their social world, family, school, community. So a proper evaluation needs multiple informants. You need to talk to parents or caregivers, the child themselves, and often get input from teachers, maybe look at school records or medical history. You're triangulating the information.
Let's start with the parents, though. The parent interview is often the first step. What's the goal beyond just getting the history of the problem?
So, you definitely need the details. How often does this happen? How intense is it? What triggers it? How do the parents usually respond? But you also need to gauge the parents' own viewpoint. What are their expectations? Are they coming in demanding Ritalin because they think it's ADHD or maybe Prozac? Are they worried they're going to be blamed for the problems? That's important to address. And critically, you need to understand how they react to the child's distress. Do they maybe over-accommodate? Like, if a child is anxious about school, do they let them stay home all the time?
Which could inadvertently make the avoidance worse?
Precisely. It can reinforce the avoidance pattern instead of helping the child build coping skills.
Okay, so turning to the child, how do you conduct the direct child interview, especially if they're quite young or maybe not very verbal?
Yeah, that requires real flexibility. The interview has to be completely tuned to the child's developmental level. Their ability to actually reflect on and report their inner feelings, their internal state, that develops gradually over time. So for younger kids particularly, you often have to move beyond just talking. You need to incorporate play, maybe use stories or ask them to draw. This process of observing them, interacting with them while gathering information that is the mental status exam for a child, essentially.
And for the really young ones, say under 8, play techniques sound crucial.
Oh, they're absolutely vital. Play is how young children communicate, often indirectly in displacement, as the source puts it. You watch the form of their play, how's their attention span, can they coordinate movements, and the content, what themes emerge, what's the complexity of their imagination. And here's a really practical tip from the source. Use simple, generic props, blocks, maybe some plain figures, drawing materials.
Why simple?
Because if you give them, say, elaborate action figures or dolls from a specific movie, they might just act out stories they already know. Simple props kind of create a blank slate, allowing their concerns, their inner world, to come out more freely.
I see. And what about getting at those deeper concerns more indirectly? The source mentions projective techniques.
Right. These can be really useful ways to bypass defenses or tap into things the child can't easily verbalize. For instance, asking something like, if you had 3 magic wishes, what would you wish for? Their answers can be incredibly revealing. Maybe it's for a new bike, or maybe it's for mommy and daddy to stop fighting. Drawing is another classic one, asking a child to draw your family. You're not interpreting rigidly, but you might notice things like the relative size of figures, who's standing next to whom, maybe who's left out entirely. It can offer nonverbal clues about perceived relationships or their place in the family.
So you gather all this information from parents, teachers, the child through talk and play. What happens when the stories don't match up, which must happen often?
Oh, it happens all the time. Discrepant reports are the norm, really, and the clinician's job isn't to figure out who's right and who's wrong. It's about synthesis. We know, for example, that parents are generally better at reporting on those externalizing behaviors, the things you can see, like aggression, restlessness, defiance.
Things that disrupt others.
Exactly. Whereas the child or adolescent is often the only one who can really tell you about their internalizing symptoms, how anxious they feel inside, or if they're feeling depressed or hopeless. So you take these different perspectives as valuable data points. They tell you how the child is functioning in different contexts and seen through different eyes.
Okay, let's shift towards making this process more reliable. Standardized tools play a big role, don't they? Can you break down the main types of diagnostic interviews mentioned?
Yeah, standardization helps reduce bias and improve consistency. Broadly, the source distinguishes 2 main types based on who's really driving the questions and interpretation. First, you have respondent-based interviews, or RBIs. Think of the DISC, the Diagnostic Interview Schedule for Children. These are very structured, like reading a precise script. Often they can even be administered by trained lay interviewers, not necessarily clinicians. They're efficient, especially for large research studies. But the downside, they can feel impersonal, maybe miss some clinical nuance.
Any other type.
The second type is interviewer-based interviews, or IBIs. Examples are the KSADS, Kid Schedule for Affective Disorders and Schizophrenia, or the A to C for anxiety disorders. These are semi-structured, there's a framework, but they require a trained clinician who uses their judgment. They can probe, ask follow-up questions, clarify answers, and then make the final rating based on all the information. More flexible, potentially richer data, but requires clinical expertise.
So beyond interviews, there's also psychological testing. What does that bring to the table that the interview might not?
Psychological testing adds that quantitative piece. It gives you objective scores, data on things like overall intelligence, IQ, academic skills like reading or math, and specific cognitive abilities. We're talking about memory, visual spatial skills, processing speed, and importantly, executive functioning. This data helps confirm or sometimes challenge the hypotheses you form during the clinical interview.
And the source flags a big shift in how we use testing for learning disorders. Can you explain that?
Yes, this is a really important evolution. The old way, under previous DSM versions, often relied on finding a severe discrepancy, basically, a big gap between the child's IQ score and their scores on academic achievement tests. You had to be smart enough to be failing, in a sense.
Which had its problems, I imagine.
It did. It could delay diagnosis for some kids or exclude others. The new DSM-5 approach focuses instead on an absolute academic deficit. The child's academic skills, reading, writing, math, have to be substantially and measurably below what's expected for their age. And critically, this deficit has to persist for at least 6 months, even when they've received targeted help or interventions. It emphasizes response to intervention before locking in a diagnosis.
That sounds more practical.
Yeah.
And you mentioned executive functioning, EF. That term comes up a lot. What exactly is it?
EF is basically the brain's management system. It's a set of mental skills that help you get things done. It includes things like planning and organizing, inhibiting impulses, shifting your attention flexibly between tasks, managing your time, holding information in mind while you work with it that's working memory. It's crucial for goal-directed behavior. And often, when you have a really bright kid who's consistently underachieving, they seem to understand the material but can't get homework done, bomb tests, lose things. Poor EF skills are frequently the underlying issue. It's not about knowing, it's about doing.
And memory assessment, you mentioned distinguishing types of memory failure.
Right. A key clinical distinction is between problems with encoding versus problems with retrieval. Think of memory like filing information away. Encoding is getting the information into the filing cabinet properly in the first place. Retrieval is finding it later when you need it. If someone has an encoding problem, the information just didn't get filed well. So giving them clues later won't help much. It's not there to be found. But if it's a retrieval problem, the information is in the cabinet, but maybe it's disorganized, hard to access. In that case, giving a cue, like the first sound of a word they're trying to remember, might suddenly help them pull it out. Testing with and without cues helps differentiate these issues.
Understanding all this is vital for a thorough assessment. But let's switch gears to a high-stakes environment, the emergency department evaluation. The priorities must shift dramatically there.
Oh, completely. In the ED, everything narrows down to two immediate, non-negotiable priorities. First and foremost, safety, ensuring the child or adolescent is safe and that the staff are safe. This means things like continuous observation, maybe removing potentially dangerous items from the room, setting clear limits and expectations calmly. Second is rapid differential diagnosis. Before you jump to concluding it's purely a psychiatric crisis, you have to quickly rule out underlying medical causes. Is this agitation due to intoxication, a seizure, a brain tumor even? Rare, but possible. And you also need to consider acute psychosocial crises. Is there sudden abuse or neglect? Has the family support system just completely collapsed? Those need addressing urgently, too.
And if the child is highly agitated, what's the approach to management?
The absolute goal is prevention of escalation and de-escalation if it's already happening. Verbal techniques come first. You want to avoid physical restraint whenever humanly possible because it can be frightening and even traumatic for a young person. So if medication becomes necessary to manage severe agitation or aggression, you always offer oral medication first. An IM injection usually requires physically holding the child down, which is a last resort. And the choice of medication should ideally be tailored. For instance, the source notes risperidone can be particularly effective for aggression in youth with autism spectrum disorder.
A really tough topic is suicidality, which drives many youth ED visits. What are the key management points highlighted?
Yeah, it's a critical area. First, universal screening is recommended, asking all youth presenting with behavioral health concerns about suicidal thoughts, often using brief standardized tools like the ASQ or CSSRS. If risk is identified, the core interventions are twofold. One means restriction working with the family to secure or remove anything the youth could use to harm themselves, like firearms, ropes, pills. This is absolutely crucial. The second is collaborative safety planning. This isn't just telling them not to do something, it's actively working with the youth to identify their personal warning signs or triggers, develop coping strategies they can actually use, and list sources of support people they can call, places they can go. And here's a really important point the source makes. Those old no suicide contracts, they are not recommended.
Really? Why not?
Because the evidence just doesn't show they actually prevent suicide. And worse, they might create a false sense of security for the clinician or even make the young person less likely to reach out for help later if they feel they've failed or broken the contract. The focus now is squarely on active safety planning and restricting means.
Okay, so stepping back from the ED and looking at the whole process we've discussed, from understanding infant temperament all the way to these advanced psychometric tests. What's the ultimate goal? What does this comprehensive child psychiatric exam lead to?
The ultimate output, the end product, isn't just a diagnostic label like ADHD or major depression. It's the diagnostic formulation. This is a synthesis. It has to weave together the child's symptoms, yes, but also their strengths, their weaknesses, their risk factors, their protective factors, things like their intelligence, their cognitive profile, the family support system, the school environment, their ability to manage emotions. It pulls everything together into a coherent picture that explains why this child is struggling now, and most importantly, guides a truly individualized and effective treatment plan. It's much richer than just a category.
That really elevates the assessment beyond just ticking boxes, becomes a personalized strategy. And maybe Thinking about it, the most provocative idea here is that the assessment itself, done this thoughtfully, can be a powerful intervention right from the start.
I absolutely believe that when you conduct this kind of deep, sympathetic inquiry, you're giving parents, and often the child too, a detailed understanding of the situation. It helps shift the dynamic away from blaming the child, blaming the parents, blaming the school, and focuses everyone on understanding the challenges and working together on constructive, evidence-based solutions. It sets the stage for positive change.
An essential foundation indeed. Thank you so much for walking us through this complex but vital clinical area. And for all of you listening, we hope this deep dive provides a solid framework. We encourage you to keep exploring and learning,